We are recording this webinar today, so it'll be available online after the webinar is concluded, as well as the slide deck. The full slide deck will be available to everyone online after following the webinar today. So thank you all so much for being a part of our webinar. My name is Marissa Tonelli, and I'm the Senior Capacity Building Manager at Health HIV. Again, would you please mute your lines up when you enter the meeting? Thank you so much. We're here hosting one of our Leadership Link and Learn webinar series, and the theme of this particular webinar is empowering and promoting HIV leaders in MSM of color communities, and we're thrilled to have two fabulous presenters, Dr. Valerie Earnshaw from Harvard Medical School, as well as Corey Yarbrough, who is the Executive Director and the co-founder of the Hispanic Black Gay Coalition, here joining us for this webinar. And we're also thrilled to be co-hosting it with the National Black Justice Coalition, and I'll let their lead, Benton Jones, speak in just a minute about their programs. So Health HIV is a national nonprofit. I just want to give you a little bit of background about our work. We do capacity building, health services research and evaluation, advocacy, and education and training. Some of our capacity building programs are listed here: ASO and CBO capacity building. We do work with health departments, health centers, and also workforce development. And this is actually brought to you by our 3D HIV prevention program, which the approach of the 3D HIV prevention program is to facilitate community infrastructure development, expand care team integration, demonstrate cost effectiveness and outcomes monitoring of programs, and to promote workforce development, including training the next generation of leaders in HIV prevention. So that is part of the reason why we launched earlier this year our ASO CBO Leadership Initiative, which includes a few different pieces. We have a leadership training and certificate program online, which is a 6-module self-paced online certificate program that you can take. We have our monthly webinar series, which this is a part of, a mentor-mentee program, and as well as an online portal that links ASO and CBO leaders to engage with one another, share information and best practices, and participate in online education and training opportunities. So if you're interested in our leadership training and certificate program, you can use this URL or go to Health HIV's website to become a certified ASO leader. We've certified over 100 leaders now, close to 150 leaders across the country. You can see where some of your colleagues have been certified on both coasts and in the Midwest so far. And I also wanted to just reiterate, we will have our slide deck available online following the meeting today. And I wanted to introduce Benton Jones, who's with us today from the National Black Justice Coalition, just to welcome you all and also to talk a little bit about some of their leadership programs and the work they're doing with leadership among MSM of color. So, Benton?
Wonderful. Thank you so much. Can you hear me?
Yes, I can.
Okay, wonderful. Good afternoon, everyone. My name is Benton Jones, and I am the program manager for MBJC's Health and Wellness Initiative. And we are thrilled today to be partnering up with Health HIV for this amazing panel discussing MSM leadership, MSM of color leadership. And so this is part of National Black Justice Coalition, is the nation's leading civil rights organization, and we're dedicated to the empowerment of Black, lesbian, gay, bisexual, and transgender people. And so part of this effort is part of MBJC's Health and Wellness Initiative that we launched on World AIDS Day in 2014 in order to really work to bring health and wellness, particularly around addressing the HIV epidemic among the Black LGBT community, back on the LGBT agenda. So again, thank you so much for everyone being on the call, and I'll turn it back over to Marissa.
Great, thank you, Benton. So without further ado, I would love to introduce our next and first speaker, who is Dr. Valerie Earnshaw. Dr. Earnshaw studies how stigma relates to health outcomes and disparities among people at risk for or living with HIV/AIDS, and what moderates these associations in protective ways. She earned her PhD in social psychology and completed the pre-doctoral social processes of HIV/AIDS training program at the University of Connecticut. She further completed the postdoctoral interdisciplinary HIV prevention training program at Yale University's Center for Interdisciplinary Research on AIDS, and she is currently an instructor in pediatrics at Harvard Medical School, as well as an associate scientific researcher at Boston Children's Hospital. So lots of accolades there, and I will turn it over to Valerie. We're going to play with having her lead on the PowerPoint, so if there's a little bit of hesitation here in the presentation, you know why. So Valerie, thank you so much for being with us, and I'm going to turn over controls to you.
Great, thank you. I just took control. Does it?
Oh, there we go.
Oops. Okay.
I have to go back a couple.
Okay, I think we're set. So good afternoon, everyone. Thank you very much to Marissa and the folks at Health HIV for inviting me to speak with you all today. I'm excited to present on the social determinants of HIV with a focus on social stigma, which, as Marissa said, is the focus of my research. So I thought we could start off by defining social determinants of health. So the WHO defines them as the conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources at global, national, and local levels. Healthy People, which operates under the U.S. Department of Health and Human Services, provides examples of these conditions. And I think that these examples are helpful for understanding sort of what they mean by social determinants and what these social determinants are. So Healthy People highlights things like economic stability, which can include poverty, food and housing security, and employment. They include education, which could be educational attainment at institutions like high schools or colleges, but this could also include things like language and literacy. Social and community context, which includes things like incarceration, institutionalization, but also social cohesion and social stigma. They include health and healthcare, which can include access to healthcare, but also things like health literacy. And finally, neighborhood and built environments, which would include access to healthy food, housing quality, violence and crime, and environmental conditions. So I'll point out two things that we might take note of here. First is that, consistent with this WHO definition, these really do reflect conditions in which we live our lives, and they're all highly related to money, power, and resources. And second, these are all related to each other, as some of you may have started to think about as I walked through the list. So as examples, our economic stability affects our neighborhoods, where we can afford to live, and our level of education affects how we access and navigate healthcare systems and might affect our health literacy. Returning to this WHO definition, the WHO says that these social determinants are mostly responsible for health inequities, which are unfair and unavoidable health differences among people. So I'm sure that folks on this call likely agree with this. You know, this idea that our neighborhoods and our access to education, as examples, can shape our health. But it's worth reflecting on how this could be considered sort of a, a big or revolutionary statement to some extent. So rather than blaming some of the health differences that we see on biological differences or differences in individual behaviors, the WHO says that differences in people's social worlds are sometimes to blame. So let's start applying this to HIV by considering what these health inequities look like for MSM of color. So these data represent Black MSM, and fortunately don't have or couldn't find a similar graph for Latino MSM, but trends are similar at many points for Latino MSM. And I'll apologize for those of you on the webinar who might already be familiar with this graph, but I hope it's helpful to just demonstrate this health inequity that we're talking about. So we are looking at the HIV treatment cascade, which begins with HIV diagnosis and ends with viral suppression of HIV. So these data compare Black MSM with other MSM in the US, the UK, and Canada. So the first thing that we see is that Black MSM are more likely to be undiagnosed with HIV than other MSM. So living with HIV but not knowing it. Next, they're more likely to be diagnosed with HIV. So the prevalence of HIV is higher among Black MSM than other MSM. As we transition into treatment, they're less likely to be prescribed antiretroviral therapy or medications for their HIV. Then they're less likely to have a CD4 count of less than 200, which means that their HIV is less well controlled than other MSM. They're less likely to make it in for the recommended healthcare visit, and they're less likely to be adherent to antiretroviral therapy even when it is prescribed. And finally, Black MSM are less likely to experience viral suppression, which is the ultimate goal of HIV treatment. So all of the social determinants of health that are highlighted by healthy people play a role in these HIV disparities. In terms of economic stability, Pawlowski et al. And colleagues note that HIV infection in the U.S. nearly exclusively impacts those who face economic adversity. Economic instability is sometimes the reason for engaging in behaviors that put people at risk for HIV, things like transactional sex. It also plays a role in whether people can afford certain prevention and treatment options. So pre-exposure prophylaxis, or PrEP, has been great, but it's also been very difficult for people to afford. In terms of education, HIV is more prevalent among people with less than a high school education. The lack of education and information can be a barrier to understanding HIV prevention technologies and also navigating the healthcare system once living with HIV. In terms of health and healthcare, Black and Latino MSM are at greater risk of other STIs and other chronic health conditions in addition to HIV. So this could increase both their susceptibility to HIV and also make their HIV more difficult to manage once living with HIV. In terms of environment, research suggests that sexual networks are a major determinant of HIV infection among MSM of color. So some research suggests that Black MSM tend to have sex with partners in networks that are highly connected, so their sexual partners are having sex with other partners in the same network. And because of how this network is structured, they're more likely to become HIV infected if HIV is introduced into that network. So the visual, you can kind of think about how a fire might spread more quickly in a forest where the trees are dense or closer together than a forest in which the trees are sort of more spread apart. They may also just live and have sex in neighborhoods where HIV is more prevalent. So you can imagine that someone having sex without a condom in the Bronx is going to be more likely to become HIV infected than someone having sex without a condom in Alaska. So HIV prevalence is higher in the Bronx, and so they will be more likely to have sex with someone who has HIV eventually, just because of the neighborhood that they live in, the place where they're having sex. So stigma is characterized as part of the social and community context, and I'm going to focus on stigma as a social determinant of health and sort of take us through some of the research on how stigma is related to inequities at different stages of the HIV cascade. So this is a model. It describes how stigma is associated with HIV disparities. So if we start on the left, we can define stigma as social devaluation and discrediting, basically labeling people as less than others due to some sort of characteristic. Now, because Black and Latino MSM and other people who are at risk of and living with HIV experience stigma associated with a range of characteristics, you can see that this model starts with stigma associated with a range of characteristics: race, sexual orientation, gender identity, and also other characteristics. The model then suggests that stigma is manifested here at the structural level. So racial residential segregation, for example, persists today with people of different races living in different places, and this is a remnant of historical racist housing and zoning policies. Historical traumatic events involve awareness of racist, often violent events in our country's history, things like slavery or medical experimentation on people of color. And medical mistrust is the resulting mistrust that people experience of the medical system, due in part to awareness of these historical events. At the individual level, right here, we can differentiate between perceivers. These are people who might perpetuate stigma versus targets, and these are people who might experience stigma. The people who perpetuate stigma may experience things like prejudice, stereotypes, and discrimination, which are generally negative feelings, thoughts, and behaviors towards people who are living with stigmas. And people who are the targets of stigma may experience perceived stigma, which are experiences of discrimination from others in the past or present, anticipated stigma, which are expectations of discrimination from others in the future, and also internalized stigma. So really believing and endorsing the negative beliefs about one's group and feeling that those negative beliefs apply to the self. So I am a bad person because I'm living with HIV, for example. So all of these manifestations may lead to HIV disparities experienced by Black and Latino MSM. So I'm going to walk us through some examples from research on how this actually plays out. So starting with HIV risk. As many of you know, data on HIV risk behaviors paint a complicated story of HIV risk and disparities. So research suggests that the risk behaviors, so things like condom or sex without condoms and substance use of Black MSM aren't greater than other risk groups. And this often holds true for Latino MSM as well. Yet, HIV is most prevalent among Black and Latino MSM. So this suggests that their environments contain greater risk for HIV, so that when they do engage in risk behaviors, they're more likely to become infected with HIV. So stigma comes into play because it shapes both the risk environments and the behaviors that people engage in within those risk environments. So at the structural level, racial residential segregation determines, in part, where people live. So Black and Latino MSM tend to live in areas with higher prevalence of HIV. Research also suggests that people who distrust the medical establishment, who are more likely to be people of color, are less likely to use condoms. At the individual level among perceivers, there's some evidence to suggest that doctors may be less likely to prescribe PrEP, which is pre-exposure prophylaxis, to Black MSM given stereotypes that they will engage in riskier sex if they are on PrEP. And there's absolutely no evidence suggesting that that would be true. At the individual level among targets, people who perceive and internalize stigma engage in greater substance use, possibly to cope with those experiences of stigma, you know, the feelings of anger that happen afterwards or the feelings of sort of sadness. They also engage in less condom use. So we saw in the treatment cascade, there we go. We saw in the treatment cascade that Black MSM experience inequities at every single stage of treatment, and stigma appears to play a role here as well. So at the structural level, because racial residential segregation determines where people live, it also determines the quality of care that people have access to. Blacks and Latinos tend to live in areas where lower quality of care is available. And due to historical trauma and medical mistrust, people are less likely to want to access that care, so they don't trust the medical system. At the individual level, among perceivers, doctors who endorse racial stereotypes prescribe antiretroviral therapy to Black patients later than to white patients. So doctors who are more prejudiced also provide worse care to Black and Latino patients, and that's not just documented within HIV, but in a whole range of care settings. At the individual level, among targets, internalized stigma, so feeling bad about oneself due to one's race, sexual orientation, or HIV status, relates to not accessing care and not adhering to one's medication. One thought on this finding is that people may avoid care and avoid medication to avoid thinking about their HIV. And then in addition, people who perceive discrimination including racial discrimination from their providers, are less likely to access care. So if doctors treat you poorly, you're less likely to want to go to the doctors. And finally, we saw in the cascade that HIV is less likely to be suppressed among Black MSM, which can ultimately mean that Black MSM die faster from HIV and AIDS than others. So in addition to the issues related to receiving poor treatment, Black and Latino MSM may experience a good deal of other stress in their lives due to stigma, which can make it harder to manage HIV. So at the structural level, racial residential segregation and historical trauma are related to greater experiences of chronic stress, so that feeling of stress that people feel in their day-to-day lives. So for example, Black and Latino people often live in neighborhoods characterized by greater violence, and this greater stress can take a physical toll on people, leading to faster disease progression. And then at the individual level among targets, both past experiences of discrimination and expectations of future experiences of discrimination act as ongoing stressors. So you can imagine, and some of us don't have to imagine, living your life worrying about how people are going to treat you due to your race, due to your HIV, due to your sexual orientation. That's incredibly stressful, and it takes a toll on health. So these are just some of the ways in which this one particular social determinant of health, stigma, relates to worse outcomes for Black and Latino MSM all through the HIV treatment cascade. I listed some resources here on this last slide that I pulled on in constructing these slides. The two are hyperlinks to some of those definitions that I gave earlier on. The Pulowski article really gets into detail about the role of poverty and other social determinants of HIV. And then the Earnshaw article that's listed after that provides all of the citations for the research that I shared in relation to the role of stigma in HIV disparities. So thank you very much for your time and attention. I'll turn it back over to you, Marissa.
Great, thank you so much. Thank you very, very much, Valerie. And I just wanted to note, we will be taking questions, but we're not going to be taking them until the end. So if you have a question for Dr. Earnshaw, please hold it for right now, and we will get back to it very shortly at the end of Corey Yarborough's presentation as well. So I'm going to let Benton Jones from NBJC introduce Corey, since they have a relationship with that organization. So, Benton, if you'd like, Corey, you're on the line.
All right, thank you so much. And so this afternoon, I am introducing Mr. Corey Yarborough, who is the co-founder of the Hispanic Black Gay Coalition and now serves as the executive director. And the Hispanic Black Gay Coalition works to inspire and empower Hispanic, Latino, and Black LGBTQ individuals to improve their livelihood through activism, education, outreach, and counseling. And so also, in addition to his role as the executive director of the Hispanic Black Gay Coalition, Corey also serves on MBJC's Leadership Advisory Council and also was just announced as one of MBJC's 100 Black LGBT Emerging Leaders to Watch. And so so excited to be listening to Corey's presentation. And so in order to get it started, I'll turn it over to Corey.
Great.
Thank you.
Oh, go ahead, Corey. Sorry.
Just saying thank you so much, Vincent, as well, for inviting me to be a part of this important conversation, and thank you to everyone on the call. So I'm just going to hop right into it, especially so we can have Q&A afterwards. But as you see on your screen, the second part of this webinar is on empowering in MSM communities of color, and the title was Empowering HIV Leaders in MSM communities of color, but I intentionally took out HIV leaders, just the importance of cultivating leadership and resiliency in a variety of areas, right? So in order to truly get to this point, we have the HIV leaders, we have to develop fertility with the end goal of being HIV prevention leaders. everyone hear me okay? Can you hear,
Corey, sorry, Corey, you're coming in and out a little bit. It's hard to hear you.
Okay, is this a little bit better?
That's much better, thank you.
Okay, all right. All right, we can go ahead and move on to the next slide.
Great.
So a quick look at the objectives for this section of the webinar. We're going to start by exploring the current lack of leadership in not only the MSM of color community, but also the LGBT of color community, and how that lack of leadership contributes to a variety of social disparities. And then we're going to review exactly what some of those challenges and barriers that block leadership development in MSM communities of color. What are they and how do they look? Following that, we're just going to explore some best practices and program models, and I've been asked to really focus in on the work that the Hispanic Black Gay Coalition is doing in this area in terms of developing and maintaining leaders of color, talk about alternative strategies for HIV prevention, and again, looking at that in a broad context, so broader approaches to leadership development and HIV prevention in MSM communities. And then lastly, share some resources and opportunities. And, you know, folks are certainly encouraged to use the chat box as well to share some of those if that's visible to everyone, or, you know, I'd definitely love to check that out later. Next slide. Thank you. So I'm sure it's helpful to put a face to the voice and the name, but in addition to just, you know, showing you all what I look like, I wanted to share my personal passion and connection to leadership development, because it's very much so connected to why I'm even qualified or even able to be on this webinar to speak with everyone today. I'm really passionate about leadership development, particularly in MSM communities, because I personally have witnessed how it can be life-changing, not only for oneself, but for an entire community. And that speaks to my experience moving to Boston and co-founding the Hispanic Black Gay Coalition with my partner. When I moved to Boston from DC, actually, about 8 years ago, I felt completely out of place. I would go to a lot of HIV and LGBT events and often be the only person of color in the room. Often feeling like, you know, my experiences and my voice wasn't being heard. And the only time really feeling like I saw something being marketed towards me as a Black male, it involved HIV testing or trying to, you know, reach testing numbers and not really caring about me as a person as a whole. And so, you know, through that experience and through complaining about those feelings and those experiences, my partner Quincy and I decided to create this organization that would be a response to the lack of leaders of color, a response to the lack of organizations that will by and for people of color, and a lack of agencies who are truly rooted in and willing to go to communities of color to engage and serve them. And so we'll be talking a little bit more later about specifically what the organization does, but I wanted to share my personal story to show how leadership development can, in a lot of instances, be a form of survival for people. So in my case, it was a way to access community. It was a way to access support and find like-minded people, but it also was a form of empowerment. So through leadership development and through co-founding this organization, I was able to do my part in pulling together the resources and the power of my own community to positively impact our community. And so there's much power in leadership development, you know, beyond what we may immediately think of for reaching our grant requirements or for trying to engage a community. Next slide, please. So as these two graphs show, I wasn't necessarily alone in my experience in terms of feeling ignored, in terms of feeling excluded, not seeing other leaders of color with faces that look like mine. This chart on the left shows people of color representation in LGBT organizations, and it uses 25 leading LGBT organizations as the sample for this graph. But what we see are some huge disparities in not only MSM leaders of color representation, but LGBT of color representation. And it starts with the staff and goes to boards and EDs, and what we see is that influence and power and decision-making ability increases, the number of people of color representation begins to decrease. And even when we look at the staff level, we see 27%, which may look good when you compare it to the general population. But unfortunately, what's not captured in this graph is that 27% of people of color on staff representation often represents entry-level positions, often represents custodian positions or assistant type of positions that have very little decision-making over the programs and the services that are geared towards or serve to impact people of color community. And again, as we look at board representation and executive director representation, we see that a lot of people who are making decisions on behalf of uplifting and serving people of color are not being made by people of color. And even though this represents the LGBT organizations, you know, this is something that we see across the board, even for HIV and ASOs as well. And in looking to the right, we see that funding as well at least doesn't proactively encourage people of color leadership. We see that a majority of grant funding for LGBT organizations are invested in non-POC, non-people of color specific organizations, leaving only 8% for people of color specific organizations. And so it shows that leadership does not exist for people of color, but not only that, funding isn't necessarily being invested in organizations that have people of color leadership. So it's no coincidence or it's no surprise why a majority of the disparities, such as HIV and such as other social disparities, do exist at such disproportionate levels for people of color when we see the leadership and the funding not directly being invested there. The impact of this, there's many impacts of this, but obviously first we see from these two graphs, particularly the one on the left, is that we're missing the voices of those most impacted by HIV. We're missing the voices of those most impacted by a lot of LGBT disparities, such as homelessness, substance abuse. I could go on. And that these missing voices and these missed opportunities prevent innovative solutions from being implemented to help directly address some of the needs of our communities. We also see from this that agencies can be perceived as unwelcoming or not inclusive of people of color. And I dare to say perceived because as we look at the graphs and as we probably reflect on our own organizations we work with, we know for a fact that it's not just perceived, but it truly is not inclusive of people of color. And so ultimately, this prevents our voices from being heard. It can also be interpreted as a failure to model your mission in terms of truly working towards healthy and empowered communities. And it can ultimately create a disconnect that I'm sure none of us want in terms of not engaging or being able to reach communities of color. Next slide, please. So in addition to why leadership development is so important for engaging the voices of people of color, for making sure that their experiences are incorporated into the solutions of your agency to accomplish your agency missions and goals, there's this greater importance of leadership development, right, that extends beyond the mission, that extends beyond an organization. But just the genuine fact that leadership development is essential to one's livelihood or to one's community empowerment and advancement. And so I encourage everyone to if you haven't already, to begin shifting your thinking in terms of leadership development and how leadership development is not necessarily an end to implementing HIV prevention programs and outreach, but leadership development itself can be a solution to HIV infections. And what I mean by that is kind of displayed in this graph here, and how leadership development leads to a variety of different skills, be it outreach skills, be it marketing skills, be it communication skills, be it research skills. Leadership development inevitably leads to some type of new skills being gained, which could lead to job advancement, greater resources, which leads to income, which leads to a solution to many of the social disparities, or the ability to tackle many of the social disparities that we talked about earlier on in the webinar, in terms of housing, being able to access quality health care, being able to cover medication, be able to accumulate wealth, which ultimately gets us to this last part of the graph, which is where we want all of our communities to be in terms of being stable, being resilient, being in a place where you can reinvest in your own community, feeling empowered, and ultimately having health and longevity. So, next slide, please. So as we shift now to talk about some of the challenges and barriers that can often prevent effective leadership development, I want to first start by looking at our own agencies, right? Because often we can get caught in blaming a particular community, or saying, I don't know why we don't have more Black leaders. I don't know why they won't come to us, or I don't know why they don't feel comfortable coming in our space. But we often don't look in the mirror enough, and we often don't analyze our own agencies and institutions to explore what we could be doing better to help various communities of color overcome a lot of social barriers and social, institutional, all the ones that are listed here, all these types of barriers that will make them more comfortable engaging our agencies, and make them more comfortable serving as a leader within some of our agencies. So I found it helpful to look at barriers and challenges to developing leaders in these 4 categories. And we often look at these 4 categories for a variety of other things, like, retention and care, or likelihood of getting tested, or being aware about HIV services. And, I think some of these same areas apply to developing leaders. So first, institutional barriers. And so institutional barriers basically represent the structure of an agency. So be it through policies, be it through procedures, how you go about your day-to-day, and how that could prevent someone from being able to access you, or feel comfortable enough to engage your organization as a client or as a leader. And on the next slide, I'll definitely provide some examples of this. But as it says here, it could be legal, it could be educational, it could be healthcare, it could be government or media. But again, it could be, I'm talking about this in context to your specific agency, so some of that may not apply. And then you have societal. So these are barriers that are based on geographic or demographic factors that can impact one's ability to access either information related to your organization, or be able to physically access your space at an agency. Then we have behavioral, which is psychological conditions, so things that before we even have, one could even have the option of becoming a leader or not, things that are immediate needs and concerns that need to be addressed first, and that can serve as a barrier from participation within the agency. And then attitudinal, so personal attitudes, feelings, and beliefs that can impact one's outlook on life and culture. So to provide a few examples of these on the next slide. And I know this can be very overwhelming, and first to say this kind of tongue-in-cheek, but if this is overwhelming, then obviously think about how it can be for a MSM person of color, an LGBT person of color, who who have to deal with a lot of these issues on a day-to-day basis, and not just one category of these issues, but, you know, intersecting, these issues intersecting on a day-to-day basis. And so, but for the purpose of this call, you know, I definitely encourage you to maybe focus in on one category and how your agency can do better in terms of creating better, overcoming barriers and creating better conditions to engage MSM leaders and potential leaders of color, or maybe think of one example in each category that your agency can do a better job at, and kind of leave this webinar with next steps in each of those areas. But as you can see, here are some examples of each of those areas. So institutional can be things simply related to the qualifications that you list for jobs or leadership development or leadership positions within your agencies. Are you requiring X number of experience? Are you requiring degrees? Are you requiring things that, based on everything we talked about in the first part of the webinar in terms of access to education and resources, are your qualifications alone excluding a good number of MSM people of color? And how can we explore what experience means and how experience is articulated in order to gain leadership roles? Another example of this can be simply how you disseminate information about leadership development opportunities. Are you simply just doing it from your agency's desk, which is located in a predominantly white community, or are you engaging community partners and communities of color, or posting things in different atmospheres and different environments that are more accessible to communities of color? So, you know, those are two quick examples of how institutional barriers can prevent engaging MSM people of color, or even prevent you from knowing who they are and engaging them as potential leaders to be involved in your agency. Societal, when we look at societal, we talk again about geographic or demographic barriers. So in terms of geographic barriers, this could be travel. So do you have a travel line item to support your leaders of color to make sure that they can get to where they need to go? Daycare as an option. Bilingual support, you know, as we talk about engaging Latino and Latina leaders, the need for bilingual support and being able to reach out to Spanish-speaking people, you know, requires a true investment where you can put your money behind truly wanting to engage in outreach to that population. At the top here, the ability to connect to your program and environment culturally, and so that can also go back to what's under the institutional slide about, do you have staff and people involved in your agency that reflect the culture, the race, the ethnicities of the people that you most want to serve. Moving on to behavior, again, this talks about addressing a lot of immediate needs that can prevent folks from being ready to step into leadership positions. So, you know, are you prepared and able to support people with some of the issues that are listed here? And even if they already are in leadership positions, are you able to help them overcome a lot of the social stressors that can impede one's ability to lead on an everyday basis? And then lastly, attitudinal category, this can involve distrust of your agency, which along with this category and all the categories, right, involves a realistic and honest look at how your organization is doing in a lot of these areas, which requires engaging MSM people of color, LGBT people of color, to truly see how you are doing. And so, you know, as you attempt to tackle these different categories, it's important to create time to have listening sessions, to hear honest feedback, and then when you get that honest feedback, take it for what it is, and to be able to respond to it by addressing some of these areas. Next slide, please. So, in addition to the barriers and challenges that a particular agency can provide or can have that blocks MSM leadership development, there's also the social context of things. And, you know, I think the first part of our webinar spoke to this really well. So especially in terms of HIV and getting into care and doing HIV outreach. But, you know, in addition to all of the barriers that we just talked about, it's still a reality that we are MSM people of color living in America. And that in addition to everything on the last slide, we have a multitude of other stressors that can impact our ability to lead or want to lead or even be thinking about leading. And so this graph kind of shows the multi-layers that these stressors can occur on. So we have stressors on the individual and the community level, which can, again, relate to our identity. So it could be in terms of, you know, struggling coming out to our family and friends, struggling coming out to ourselves. It could be stressors related to our HIV status, our immigration status, all of the things that we have to get a solid grip on before even embracing leadership development opportunities or being able to effectively embrace leadership development opportunities. And then as we broaden out, we see the impact of extended families, our neighborhoods, mass media. So going back to my personal experience of feeling like the only time my identity as a Black gay man was being affirmed was when I saw HIV testing ads, and the impact that mass media or the media that we promote through our agencies can play on one's willingness to embrace our agencies, but also one's willingness to embrace our own identities and to be prideful and happy within that. And as we extend either further out on this microsystem level, you see that the impact of culture of laws, of social conditions, and even history can play in one's ability to not only embrace their identities, but to embrace a particular agency, to embrace the topic of HIV, to want to be an HIV leader. And so, again, I know this can be very overwhelming, and it can be like, oh my God, how do I solve all these things? But I point this out to show the complexity of working with MSM communities of color, and not only to show the complexity, but to show why an intersectional lens is so important when we think about solutions and when we think about leadership development, because while you may not be able to tackle all of these things, it's important that you're intentional in how your programs and how your leadership development opportunities touch on these things or help people come to grasp with some of these stressors. Next slide, please. Similar slide, I'll go through this one really quickly. So these are more or less more examples from the last slide. So to give more context on the different types of stressors that MSM, particularly MSM people of color, can face, education level, access to healthcare, internalized racism, which was talked about, you know, on the first part of the webinar, employment status, and various different types of coping mechanisms that we may use in terms of trying to feel comfortable with our identity or trying to feel comfortable being a part of society. And, you know, again, the last thing I'll say about this is that, you know, it's important to take these stresses into consideration. We may not think they're directly involved with HIV prevention and education, but when we talk about leadership development, unless we are doing our best to tackle some of these stressors, it's highly unlikely that we're going to be able to produce resilient, sustainable, truly empowered and resilient leaders if part of that isn't helping individuals cope with some of these stressors. So next slide, please. So now that we understand a little bit about some of the challenges, some of the barriers and stressors that prevent leadership development and that kind of keep a lot of those statistics so high that we saw in the first chart, you know, now I want to turn to how do we develop positive MSM leaders and positive LGBTQ leaders of color And, you know, the model that I use typically follows these 5 bullet points. Most of the programs that HBGC offer, which we'll talk about after this, follow this template. And, you know, the first is building self-esteem, self-worth, and self-sufficiency. And so, you know, often, and I think with all these bullet points, you know, again, my goal here is to broaden our thoughts and broaden our approach to leadership development. And so typically, while a lot of HIV programs and services may not do this, again, it's essential in terms of building sustainable, resilient leaders. And so, again, the first of that is building self-esteem, self-worth, and self-sufficiency. So giving your clients and giving the leaders that you work with a sense of direction and purpose beyond your organization's mission. So when I say self-worth, I don't necessarily mean, oh, you met your professional goals for the month, you must have a lot of self-worth. No, I really mean like when that person goes home and lays their head down at night, they have worth, they are proud of themselves, and they feel like they are somebody, and not just because they accomplish your organization goals. And so programs that build that self-esteem, which revolves around focusing on the strengths of an individual, or at least cultivating the strengths of an individual, which goes back to giving hard and soft skills to individuals to make them feel like they're contributing something to society and that they have something worthy to contribute to others. Also falling into this category is realizing that MSMs of color are the expert in their own experience and the expert in their field. So, you know, while many of us may have great degrees that we work very hard for about how to respond to epidemics and disparities in our communities, it's just as important to acknowledge that individuals who have lived that since day one, or individuals who are still struggling through that and experience those disparities on a day-to-day basis are experts too, and that their voices are just as valuable. And, you know, not only their voices, but their skills and their hands to implement their own solutions are just as valuable. And then self-sufficiency. So by self-sufficiency, I mean, are you valuing the expertise? Are you valuing the skills that your leaders are contributing in a meaningful way? And yes, that means to giving them a livable income and wage, but to also just intrinsic rewards through the workplace. So second, addressing real and immediate needs, and we kind of talked about this when talking about attitudinal and behavior barriers that populations can face. But we have to often ask if our approaches to leadership development and HIV prevention inclusive of the real and immediate needs of our audiences. So, for example, if a MSM person of color is living in a neighborhood where there is a lot of violence on a day-to-day and nightly basis, are we helping them survive in that type of environment or get out of that type of environment so they can come in and be effective leaders? So it's acknowledging that, you know, supporting and cultivating leadership is doing more than just training someone how to do an HIV test or training someone how to talk to another individual about HIV, but it's supporting them and helping them thrive within their own environments and overcome some of those social ills that are disproportionately impacting communities of color. 3, inclusive programming, design, and implementation. And this means all levels. So from helping to brainstorm a new program to helping to decide what the marketing and the communication of that program will be, to helping to select the program participants in that program, to helping evaluate the program. People of color, or whoever your target demographic is for leadership development, need to be involved from beginning to end. Again, not only does that go back to the self-worth and self-esteem that will come from that, but it will, again, allow you to pull from that expertise of the people who are a part of the community and also the resources and connections that exist within those communities. And so it's very important that it's not just one part of that process, but it's the full part of the process, so an individual may not feel tokenized by that. building positive bonds with the entire community, and cultivating safe and supportive relationships. And so building positive bonds with the community, that's the entire community. So when we deal with MSM people of color, it's very important to remember intersectionality and to remember that they're not just coming in as possibly just an HIV positive person or just a gay man, but they may be coming in as a gay man who is Black and who is HIV positive, and that they need to be connected to all parts of those communities separately, if not together at one time. And so it's very important that as you think about leadership development, how you can incorporate those elements. And you know, many studies, one study in particular by Advocates of Youth, which will be on the resource slide, shows us that when people are forced to choose between their identities, often the racial and ethnic identity is the one that they select over all others, which could lead to a missed opportunity in terms of resources and again, connecting a variety of community for self-empowerment. And then lastly, cultivating safe and supportive relationships. Next slide. Which I will try to talk about that last one and some of the other bullet points as I kind of go through a little bit about my organization, the Hispanic Black Gay Coalition, and how we try to do our part, our little part, to accomplish, you know, a lot of those bullet points. And so, quick overview of the Hispanic Black Gay Coalition as an organization. We are the only organization with employed staff in the greater Boston area that is solely focused on the Black and Latino LGBTQ community. While we don't think of ourselves as an ASO or an HIV prevention organization within itself, we do view ourselves as a social support and community empowerment organization. And it's our belief that through offering social support and through offering community empowerment, we do prevent HIV, or we promote prevention and education by cultivating healthy, resilient people. We were founded in 2009. We have a staff and a board that's 100% people of color, and we do try to represent the entire community that I was just speaking on the last slide, not only by where we host our events and our organizations, but our office is literally housed in the basement of a historically Black church in the South End. And so for folks who know Boston, the South End is a traditional gay neighborhood, but yet we, you know, are in a Black church in the gay neighborhood of Boston. And so we often are trying to speak and meet directly that intersection of the communities that we serve. Next slide. Thank you. Our mission is listed here. So again, social support and community empowerment through improving the livelihood of our individuals through activism, education, community outreach, and counseling. And, you know, our ultimate vision is LGBT unity. Obviously, it's particularly among Black and Latino communities. But we also have a secondary mission of fighting racism in the mainstream LGBT community, as well as fighting homophobia and transphobia in Black and Latino communities. And so, you know, again, we take the intersection very seriously in terms of hopefully creating a condition where we can bring our full self into a room. Next slide. To quickly walk you through the start of the organization, to just give some emphasis on how HBGC went about developing leaders and developing this organization by and for Black and Latino LGBT people. We started actually with this community survey that you see on the screen, which was done in 2009. And this was our way of doing a community assessment to literally see what type of programs and services Black and Latino LGBT people here in Boston were interested in doing. And, you know, what's funny about the survey is now, being 6 years later, I look back on it and be like, oh my God, I can't believe, you know, we used this type of wording to say this, or I can't believe we excluded this. But, you know, I think what's important to take from this is that we did it, right? So we had an intentional effort to collect information back from our community, and we not only collected the information, but we tried our best to listen and to respond with programs and services that we had the power to do. And so a lot of our programming that still exists today, like our mentorship program, like a lot of our HIV support services, came from this survey and came from ideas that came from this survey. But from this community assessment, we did focus groups and we did interest meetings. They got people talking and got people excited about the idea of an organization like HBGC. And then from there, we were able to cultivate volunteers to do the work and to help us get some of these programs and events off the ground. And through that cultivation, we were also able to have some internal fundraising and skills sharing sessions where we were able to develop each other as leaders by sharing what our strengths were as professionals and as people who are a part of this community, and then beginning to do small fundraisers that became the foundation for the organization. In addition to that, I'll just also mention that it required collaborating with others because we're not a monolithic community and we're also not a one-issue organization. So, you know, we've relied on a variety of like domestic violence organizations, a lot of faith coalitions, a lot of ASOs to support our work and to allow us to support their work so we could be that link or connection to a variety of services. Next slide, please. So, you know, as a result of that community assessment and all of those listening sessions came these areas of programs. So everything HBGC typically does fall into one of these categories, coming out in peer support, HIV and STI education and prevention, spiritual growth, civic engagement, community building, and youth leadership development. And I can't underscore, I can't say enough how community building played a huge role in the launch of the organization in terms of being able to bring like-minded people together, to share experiences, to talk about those feelings of isolation, and to just give folks a space to connect. You know, kept people coming back, so built the trust of the organization, and got the ideas flowing for doing a lot of our programs. Next slide. So the next 3 slides, I'm just going to spotlight three or four programs in particular that are leadership development in nature. And again, for most of these, you may not immediately think, oh, this is an HIV prevention leadership development opportunity, but you will hopefully see the connection in terms of addressing a lot of the stressors, addressing a lot of the challenges and barriers that we talked about on the earlier slide. So the first one is our Todos Leadership Crew. And so the Todos Leadership Crew is a bilingual program for LGBT survivors of partner abuse or other forms of violence. And so it's a 12-week program where there's a mixture of healing practices, a mixture of trainings to just develop knowledge around partner abuse and the cycle of oppression and violence, as well as community organizing and event planning trainings. And so the idea is that this group of individuals connect as a community to talk about their personal connection to violence, to heal as a community, but also to eventually be at a place to give back and to implement something meaningful for violence prevention, be it coming up with a training, doing a public awareness campaign, but being empowered to give back and make a difference. And we have a similar model for this that's just focused on youth, which is our New Leaders Institute. And so, again, this program in particular helps people not only overcome language barriers, but it helps them heal from violence, which, you know, can be a huge barrier that prevents someone from engaging in healthy practices or feeling engaged or connected to their community. So that's our Todos Leadership Crew. Next slide, please. Thank you. Our LGBTQ mentorship program, as it says here, pairs LGBTQ youth of color under 21 with professionals of color over 25. And then the mentees work with their mentor to literally come up with a work plan for their 6 months about what goals you want to work towards. And a lot of these goals, surprisingly, end up being revolved around health. So That could be as simple as, getting a game plan to exercise more and eat healthier, or it could be things around sexual health and behavior. And so our mentors are strategically placed and trained to support mentees with whatever goals, be it health or be it professional, that they want to work on. And while the program is happening, our mentees go through professional development days or every other month or so throughout the 6 months that will help, develop their skills. And so this is a cool program that a lot of LGBT organizations don't want to approach, but I'm glad we did because it is very helpful in terms of encouraging intergenerational connections. There's a lot of wisdom that could be passed down and shared by that, as well as, again, having that one-on-one coach to help you through a lot of health and personal and professional navigation. Next slide, please. And then we have our GSA development opportunities, which basically identifies high school and middle schools that have a high student of color population. We cultivate leaders to serve as Gay Straight Alliance leaders or officers for their student group. And then we work with the group to organize events or public awareness campaigns that kind of speak to whatever they think is an important issue to address at their school. And what we've found through working with our first GSA at the Jeremiah E. Burke, our co-founder, Quincy Roberts, has done an amazing job with that school in terms of building partnerships, particularly around HIV awareness, where the school, to give an example, you have here, the GSA put on a Fashion Against AIDS, where we had a student at the school's mother speak about being HIV positive. We were able to actually test students at the event, give out condoms at the event. So that was an incredible opportunity to engage high school students on very serious topics. We've also partnered with the library at this school to have HIV testing events. So it was a creative way to engage people outside of our agency, outside of our office, and take it directly to the schools and have a positive impact. Next slide, please. And then lastly, I think it was something HBGC is known for is doing some very unique and innovative community forums. If nothing else comes from these forums, some fantastic conversations and resource sharing definitely does happen. And so this is just a sample of some of the forums related to HIV that we've done in the past. Our Fantasy versus Reality Weekend engaged some of our favorite gay male porn stars to not only get people excited to meet their favorite porn star, but on a serious note to have important conversations on the impact that porn can have on sexual behavior, and just to talk about as a community how as Black and Latino men we are often sexualized, and that leads to a hypersexual culture, and what impact does that have on our sexual behavior. And so that's kind of what that weekend represented. We've used the arts to talk about the impact of HIV and AIDS. We've had bilingual events geared towards the Latino community to talk about the impact of HIV in the Latino community. We've brought services directly to the community by having health expos. We've taken action to our state house to advocate on issues related to HIV. And we've had panel discussions on, again, a lot of the challenges and barriers that can impact HIV, such as immigration status. And through those panels, we've been able to connect people to lawyers and to resources that can be helpful when navigating some of those intersectional issues. So I think I'm a little over, so I think we'll wrap up there. I'm definitely, we'll welcome questions or the sharing of additional resources. But here's some final resources that I would love to share with you. The first two are leadership development programs that I went through and found really, really helpful. The first is the Young Black Gay Men's Leadership Initiative. So if you have people of color already involved in your organization, this is a great fellowship to send them to that will further develop them as leaders, particularly around HIV and AIDS. So that is one to check out. The 21st Century Pipeline Program is a project for LGBT managers of color that I also participated in. So it's about supporting people of color who get into these higher senior management positions and helping them stay there, especially when they are often the only person of color on their senior management team, or they are the ones leading the entire organization. So I found that program really helpful for that. And then we have MBJC, which we've talked about already in their programs. And then the rest are some great resources for not only leadership development for HIV in communities of color, but also some great resources that talk more about youth development, general leadership development. And the last resource I will talk about is the racial equity tools, which includes some cultural competency assessments. So if you're unsure how competent your organization is when dealing with Black MSMs or dealing with Latino MSMs, this is an amazing resource that you can use to answer some questions, and it gives you an assessment of how well your agency is doing. And if anyone is looking for that, in particular for the Latino community, Casa de Esperanza is an amazing organization that we work with as well that I meant to add to the slide here. So on that note, I will wrap things up, and thank you for listening, everybody.
Great. Thank you so much, Corey. That was really fabulous information. And I did want to take a minute to see if there are any questions from the folks on the line, either for Corey or for Dr. Earnshaw. And I do see one from somebody named Eliza. And so I'm just going to open up your line, Eliza, or Eliza, sorry if I'm pronouncing that wrong. So if you have a question for either Dr. Earnshaw or Corey, please go ahead. You're there.
Oh, hi, this is Eliza. Can you hear me?
Yes.
Oh, hello?
Hi, we can hear you.
Hi, sorry about that. Actually, I didn't have a question. I was just commenting earlier about I was having trouble with the volume. But no, this was very informative. Thank you very much. I don't have any questions.
Great. Thank you so much for your feedback. So if anyone else has any questions, you can either put your question in the question box or chat it to the host or presenters, or host and presenters at this time, or you can also have the option to raise your hand, and these are all options that should be on your WebEx on the right-hand bar available to you. So I'll just wait a couple more minutes, and if there aren't any questions, we can take some later on by email if need be. And I don't see anything else popping up at this time. So I'm going to head and I know we did go a little over, so I'm going to go ahead and move on. Oh, I see one. Never mind. Oh, there's a couple of questions, I think, from folks, too, which I'll get to at the end about where the presentation will be available, so I'll go ahead and get to that now. So if you're interested in downloading either the webinar recording, as I mentioned, this will be recorded or has been recorded and will be posted online, as well as a PDF of all of the presentations, the slide deck from today. And if there are any questions that come up either after the session or otherwise, feel free to email me and I'll share my contact information and I'll make sure that it gets to one of our fabulous presenters too. So you can go to healthhiv.org to access any of our resources, but if you do /resources/webinars, you can get to all of our webinar recordings, and this will be posted within 24 hours for you to view and download. I also wanted to let you know that we're having an upcoming webinar, and this is not actually a part of our leadership series, so that's a mistake there, but this is related to transitioning from ICD-9 to ICD-10 billing codes. So if you're interested in billing, then you can certainly go to our website and register, and also here's a short link to it, a tiny URL link as well, where you can register for this particular webinar on ICD-10 transition. which will be next Wednesday, May 28th from 3 to 4 p.m. Eastern. Great. And this is my contact information here if you're interested in our 3D program from Health HIV or the National Center for Healthcare Capacity or additional resources. There's a couple of questions coming up that I am going to ask, I believe probably Corey, to answer that's coming up in the chat box. But I also want to remind you, those of you who are signing off soon, that we will have an evaluation that automatically pops up. I would truly, truly appreciate you filling out the evaluation. It is 7 questions. It's very, very short, just to assess the knowledge attainment from this webinar and whether it was clearly presented and you enjoyed the presenter. So hopefully you will be able to access that and complete it for us. So there's a question from Ricardo Jackson that I believe Corey can answer. Corey, if you're still on. Is there a leadership program that travels around and recruits and trains young leaders, or is there technical assistance for starting such a program? So I guess the question is, do you know of something that exists that's a program like that and is specific to Hispanic and Black LGBTQ leaders?
Mm-hmm. It's a really good question, and unfortunately, not many come to mind. You know, I did on the resource tab at the end of my slide mention the Young Black Gay Leadership Initiative, YBGLI, which doesn't travel around, but the individual would have to travel to wherever the training or the weekend is being held. But again, that's something I participated in that was very helpful in terms of, in particular again, HIV, developing me as a leader and getting me to think about my approach to HIV advocacy and leadership. And so I definitely recommend looking into that. And I'm not sure if you're in the New England area, but in terms of TA, technical assistance, I know of a few consulting organizations in New England that help with that as far as providing like the technical assistance to developing programs or evaluating programs. And, you know, again, two that I know of are Third Sector in New England and Casa de Esperanza. So, you know, those are 2 that I can suggest looking into. And in terms of interventions, you know, again, I don't know many, and that's kind of why HBGC is an organization, you know, developed our own and really used the needs of the local community and collected that information of the needs and the desires of the local community to kind of design our own. So, you know, hopefully, you know, you're not discouraged by my lack of an answer, but hopefully it will be motivation to do that community assessment and to do listening sessions to hear what people actually want and what they're willing to take a part of. So yeah, I hope that was helpful. But I was also going to mention the interventions, like the CVP interventions that HBGC did in a lot of our earlier years. So like empowerment, popular opinion leader, you know, those are maybe models you can look at and then again tweak or cater to make your own. But those are all the things coming to mind right now.
Great. And I also see one other, oh, I don't know if I can get the line. So actually, I think we're going to close out with that because it doesn't look like this person's connected to audio. But again, if you have a question that wasn't answered today by any of the panelists, please feel free to contact me. My contact information is here on the slide, marissa@healthhiv.org, and I'm more than happy to forward it to either Corey or Valerie Earnshaw to answer. So thank you all again so much. Thank you, Dr. Earnshaw, and thank you, Corey, so much for presenting and sharing your thoughts about MSM of color leadership. And we will close out our session with that. Thank you all so much. Bye-bye.
Thank you. Thank you.
Thanks, Marissa. Thanks, Corey.